patient mesti ada diastolic dysfunction. You need to look hard for the diastolic dysfunction. Usually ada 4 je kan? Go back to the first one. Ada 4 je makan. Dia ada 4 je kan? So which one that you see that is one glance you saw this patient mesti ada something. Then you need to look hard for the things. Then look hard for the diastolic dysfunction. Ini kan? Ada 4 je. EE prime, septal and lateral, TR, velocity, LA volume. I think Hanif show you the 2016 punya guide, tapi 2025 baru keluar last month. So there's a new algorithm. So that's why they no longer use the 4 parameters that mentioned in the 2016. If you siapa yang guna 2009 ni dulu? Siapa pernah melalui 2009 ni? Okay, so masa saya ambil exam tu 2009 punya guideline. Lepas tu 2025, 2026 dia tukar. So saya ambil kali kedua exam tu dia tukar guideline baru. Lepas tu guna guideline baru. So now it's 2025, so you got change again the new guideline. So it's actually the perubahan tu is based on the change in the evidence. So that's why from 2009 punya guideline got 9 parameters. 2016 punya ada 4 parameters. So 2025 tinggal 3. Okay, so they remove LAVI. So now LAVI no longer inside the first criteria. Okay, kenapa? Because of the evidence. If you do echo for all of you here, some of you LAVI will be high. Tapi are you diastolic dysfunction? No. Because if LAVI more than 34 can be present in the normal population. So that's why they remove the LAVI. So the LAVI will be part of your assessment if you are indeterminate. Okay, if you don't have fulfill other criteria, you only use LAVI. Okay, so now the criteria change from 4 become 3. So the 3, if you look at the 3, the first criteria is your E prime. Okay, so E prime to septal is less than 6, lateral is less than 7. Kalau if you follow the old guideline, is 7 and 10, right? So the new one, they change to 6 and 7. This is also based on the study. So the cutoff will be less than 6 and less than 7 for lateral is significantly show that there's problem with the diastolic dysfunctions. So this is the first criteria. Kalau kamu tengok, kamu buat PDI kan, tissue Doppler. If you saw the septal 6 or below, you have to think for other parameters already. Okay, faham? So average is 6.5, tapi ambil 7 je lah. Kalau ambil hafal 6.5 ambil 7 je. Okay, less than 7, then you have to look for other cause. And then for your EE prime, if you notice that the septal is 15, lateral is 13, average is 14. So if you look at the 14, it's sama dengan siapa dekat lab. If you do the right heart study, kan your LV, EDP, your wedge pressure, all the cutoff is 14, betul? So all these are based on surrogate marker of your invasive. So echo adalah non-invasive makan. So all these measurement are based on invasive punya. So that's why all the cutoff is all same. Ingat tak? LVEDP, your wedge pressure, your EE prime, all are similar. So it's related to each other. So when you have your EE prime is more than 14, automatically you have to think of this is something wrong with the LV filling pressure will be very high, and the left atrial pressure will be high, and most likely the wedge pressure also will be similar. Okay, so this is point towards masalah left heart. Okay, because if you do right heart study kan, your wedge pressure is more than 40, then you have to think of something wrong with the right heart, left heart. Okay, and then your TR velocity is assessment of your, is same all these things are assessment of your RV systolic pressure, which is equivalent to your PSP. Okay, so your formula of PSP is your 4V square tambah LAP, tambah RAP you dapat the 35. Okay, faham kan? Siapa yang nak pergi ambil exam? So when you have these three, all normal you consider as normal. If you have reduce E prime sahaja, then you look for other parameters. Kalau tak ada parameter ada, only one criteria fulfill, you look for EA. So EA is less than 0.8, is still normal LAP, but grade 1 diastolic dysfunction. So commonly seen in elderly, orang yang tua, elderly patient. When you scan the echo, you get this. Okay, it will be normal left atrial pressure, but grade 1. Or patient have some other problems that you scan echo, then you get under this. When your EA more than 8, then you look for other criteria to grade them. Okay, if you have 3 fulfill, it's automatically increase LAP. So then you look at EA, then you look at the EN to decide grade 2 or grade 3. Okay, so masalah adalah tengah-tengah. So when you have increased TR or TR velocity or increase EA only or any two abnormal, so you only go through this tengah-tengah indeterminate to grade them whether they are in normal LAP or increased LAP. So from original 9 parameters become 2016 become 4, now become 3. So it's actually no more algorithm 1, no more algorithm 2. So will be the unified combined become one algorithm only. So it's much easier. So this algorithm only can be used if you don't have that yellow box masalah. If you have MR, MS, MAC, AF, patient on LVAD, patient have pulmonary hypertension, patient have transplant, pericardial constriction, all these cannot use algorithm. You need to use other algorithm, other parameter to help you to decide. Simplify, kan? This is more simplified than the original 2016. Okay. Cuma 2025 the number all changed already compared to the old one. That's why over the years you compare 2029, 2009, 2016, and now the number keep on changing. Okay. Okay. Why is it important? So it's LV diastolic dysfunction equivalent to HEP. That's how you mentioned HEP. So is it equivalent? Sama tak? HEP dengan diastolic dysfunction? Actually tak sama. Okay. Your diastolic dysfunction is part of your HEP. Okay. Heart failure preserve EF. Even though EF is preserved, some patients will have this LV diastolic dysfunction, but they need to have sign and symptom of heart failure plus your echo findings, or sign and symptom of heart failure plus NT-proBNP ambil darah. So or sign and symptom of heart failure plus right heart study or left heart study. So all these are categorized under that definition of HEP. But LV diastolic alone doesn't equivalent to HEP. So if you do echo for most of the patient, MI, you get this, right? Diastolic dysfunction. Are they categorized under HEP? No. Okay. So they don't have sign and symptom. They are not categorized under HEP yet. So until they develop symptom in future, they may have these changes. So that's why those patients have LV diastolic dysfunction for whatever reason, but no symptom. This group of patients need to follow up. They akan develop symptom in future. You don't know when. That's why he mentioned in the study. That's why he mentioned the old study, right? They did all the CAT for the patient, but then these are the early sign of to show that the patient will develop heart failure in future. Cuma tak tahu bila. Okay, some patient may not have symptom until dia mati. Some patient will develop symptom earlier. So that's why monitoring is important. Apa lagi ya? Just now, why they use the E prime only? They don't care about the EA and don't care about the E and the rest of the things. Why? Because if you measure EA, perasan tak siapa yang buat? Anyone do DSE here? DSE. So what happens when you do DSE EA or do exercise stress echo? What happened to the EA?
Fuse.
Fuse kan? So tak boleh nampak kan? So and it's E velocity is actually preload dependent. It can be affected by any other condition. Your tachycardia lah, your volume change your E will be changed as well. And then but the E prime you won't change so much. It's preload independent. So whatever the condition of the patient, the E prime won't change. That's why in all the study you look at the E prime, you always use the E prime as the first markers of measurement. So once you have this, you look for other parameters to help you to get to the diagnosis of LV diastolic dysfunctions. Okay, and if you look at the previous study, 2016 algorithm they did a validation study again. So in the study, if you look at the normal populations, some of them will have this abnormal in your TR, Vmax, normal patient, but then they have this TR. If you do echo for normal patient, if you do all of you echo here, some of you will have TR, correct? So are you saying that you're having diastolic dysfunction? No, kan? You only have one parameter, so it doesn't fulfill all these things. Understand? So I saw quite a few patients from one of the district hospital, mention number, always diagnose the patient have pulmonary hypertension, which I don't understand, especially in pregnancy. Okay, when a patient is pregnant, and then you do, for whatever reason, they order the echo, just because of TR, you measure it's become more than 2.8 lah, or 2.4 lah, then you label straight away as pulmonary hypertension. Is it correct? Okay, you don't diagnose pulmonary hypertension based on one parameter only. Is to help, the parameter is to help you to investigate other cause. If the patient doesn't have any other cause, don't label them as pulmonary hypertension. Then they will kena masuk apa tu? Combined clinic. Masuk combined clinic. Dah lah combined clinic tu dah penuh. Masuk lagi combined clinic. Lepas tu macam-macam investigate. Eventually normal. So patient have to go through. If the person who joined the combined clinic doesn't have knowledge of cardio, they will do what? CTPA lah, this and that. Unnecessary for the mother. Exposure to all the things. So that's why these are the problem when you label the patient wrongly, different diagnosis. This is what you get. The hospital always come out with this report, which I don't understand. So which cause a lot of confusion among the ONG people. So they don't know what to do with this group of patient because the report is coming out from you just mentioned there. You just write TR macam tu, PSP macam tu. So you anggap is pulmonary hypertension. Kesian lah the mother. Okay. And then one more thing is what I give the sound. Just now you mentioned about the EA. In a young patient, your EA always will be high. If you do all of you, EA must be more than 2. Why? Because you are young, your heart is still normal. That's why if you remember your heart muscle, you have different muscle, right? You have a longitudinal muscle, spiral, and also your radial. That's why the heart is squeezed, okay? Squeezing out the blood. That's why your EA is high in a young patient. Okay, so EA alone, you cannot use it as a parameter to help you to classify the diastolic dysfunctions. So you only use it when you have abnormalities that you suspect. For example, patient have restrictive cardiomyopathy, that you have abnormalities in the myocardium to begin with. So EA will be very useful. But if the patient is normal, don't use the EA because EA will be very misleading. If you follow the algorithm, EA 1 and 2 automatically grade 3, betul? Betul kan? Okay, so these are important. And then at least usually the LA size will be slightly bigger. That's why if you measure their LABI, they always be big. So are they having diastolic dysfunction? Only one parameter is not considered. Okay? Okay. Anything you want to ask?
Yeah, actually I have a question on that. This one. These are the additional parameters, right? Which are the ones you would say memang we always measure?
Okay, so the one in the old guideline 2009 and 2016, all these are included in the parameters, but 2009 they include everything. 2016 they remove all this to use in the indeterminate conditions. So for example, when you measure, you don't know they are grade 1, grade 2, grade 3 cannot fulfill the criteria. They are in the indeterminate. They only use this. Same thing for the new algorithm. All these measurements are all under the tengah-tengah one. Just like you saw, right? The gambar tengah-tengah one. All the measurements are all under the tengah-tengah one. Okay, so all are categorized under here already. So if you see this, your SD ratio, your left atrium reservoir strain, your LAVI is all under categories of under the indeterminate. So if you cannot fulfill the criteria, you don't know where to put them, then you have to use these other parameters to help. Okay. So same thing as your previous algorithm. Our previous algorithm got different. You got first algorithm 1, algorithm 2, right? So this one only one algorithm, but you group them under the same thing. Okay. So that's why they put here as alternative. If you cannot measure this, you measure this. Okay. If you can measure this will be better. Okay. LA strain not widely available because you need the software to help you to measure, unless you can measure straight directly from the machine. Okay. If not, you have to spend your time do the because LA strain got two way. One is you need two view, 4 chamber and 2 chamber, focus at the LA. So you need to make sure your LA is axis is correct, and the LV you can foreshorten, no problem. But you make sure you focus on the LA, then you capture the two view, 4 chamber and 2 chamber view to get to the LA strain. If you're using the GE machine ada dua view. Okay. But for Philips, you can use single view, 4 chamber focus LA, so you can get the LA strain straight away. Okay, Philips also can do biplane for LA strain as well, but then you use the software, you can straight away get the LA strain. Okay, problem with LA strain is also age dependent. So young patient have different range, mid range have different range, elderly have different range. So, but they use the cutoff as less than 18 is significant. Okay. LAVI, same thing. LAVI doesn't mean for 34 is abnormal. More than 28 already show that it's to be dilated. Cuma LAVI itu susah. My wife also LAVI is high. So is she having symptom? No. So LAVI is a bit misleading. IBRT will be a good option if you don't have, if you are busy, don't have other things, want to measure all the things, then you use the IBRT. Then you can know that the patient will be belongs to where. So now become famous, become more frequently people do is this: when you have grade 1, when you measure everything is grade 1, but they still have symptom. So to prove them, some patient doesn't have symptom at rest. When you measure all these things are at rest, correct? Patient datang echo kan resting. So you buat echo, no symptom masa tu, you do echo, you get these parameters. But they're only grade 1, but they go home, they're still having symptoms. So that is on exertion. So that's why we do diastolic exercise echo, diastolic stress test. So this will be better option if the patient can run on the treadmill or run on can do the bicycle. Kita tahu bicycle. So supine bicycle lah. So you can do patient lying on the bed cycling. Then the cycle bukan cycling yang normal yang dia ada macam stress test machine punya tu, they got different level. So if you measure the diastolic stress echo, you also looking at the EE prime, and also your usually EE prime is the one that give you the answer, because EE prime for patient at resting maybe less patient do 10 plus. So when you do the exercise stress echo, the EE prime will be high, maybe can 16 or 18. So these are, you prove that the patient having symptom during exertion. That's why the patient having symptoms of heart failure, so not so breath, exertional dyspnea. So that's why the diastolic echo, stress echo will be very useful. This is for non-invasive. For invasive, masa right heart cath or left heart cath, they also can do the cycling. This is Malaysia tak ada lah, okay? Dekat overseas je ada. So you ask them to do it because at resting, your wedge pressure, your LVADP is low in the normal range. So when they do exercise on table, masa buat right heart study tu, then you will see the change. Then that is how you get the diagnosis. Tapi that's invasive way kan, susah kan nak buat. So non-invasive way will be easier. Ask the patient to run. If patient can run, you run the treadmill, you scan masa tu, masa peak exercise. So you see the difference. Okay, so very difficult to measure the EA masa exercise, betul? Your EA is fused. So that's why you don't measure the EA pertama kali. So when the patient habis lari, ask them to lie down. You measure other parameters first. Your your tissue Doppler will be easier to measure because you won't fuse as compared to your EA. Okay, you can measure other things first before you measure the last will be measuring your EA. Okay, kalau you want to do the heart failure preserve EA punya measurement, these are all these things that you need to measure. That's the proper way lah. Okay, if patient cannot run on the treadmill, the bicycle lah, then you have to buy the bicycle machine. I think it should be very useful for pulmonary hypertension clinic punya test.
Sorry doktor, nak tanya, boleh doktor komen tak macam mana cara yang terbaik untuk buat valsalva maneuver tu? Lepas tu measurement sepatutnya waktu bila? Tarik nafas ke selepas nafas ke?
Yeah, so if you look at the mana valsalva, you can put your valsalva.
I just mentioned positive and negative.
Ini usually saya tak buat lah valsalva because it's not it's operator dependent and the measurement always vary. See mana cara Okay, so when you do valsalva, right? So this one is very difficult because you need the patient be cooperative. Patient kena ikut arahan tu. So when you do the valsalva, you can ask them to yang paling senang adalah if they can close the nose and macam nak meneran. Okay, so then you measure. That's why you slow down your sweet speed. Kan, you slow down your sweet speed. Then you look at the change in your E over the times. Okay, so when they do, then you measure from the paling tinggi sampai paling rendah. So when you start and to the end. Tapi this one, a lot of patient cannot follow the command. So contohnya sebab you waiting makan, you're waiting sebab you slow down the sweet speed makan. So when they do that, halfway dia akan bernafas sikit. So it's very difficult. Okay, so that's why I usually skip this. No point you buat yang ni. And then the other way is one of the wave yang tadi dia tunjuk tadi. Just how he got mention here. The L wave. Okay, a lot of time you will see L wave, right? If you see the L wave, patient have symptom 1, L wave is actually quite significant. Tapi L wave can be present in a normal person if the heart rate is very brady. You can see the L wave. But this L wave in those that patient have brady lah, normal patient one, the L wave is not, the velocity is not high. Usually the velocity is less than 20. So for them to be significant, usually it's more than 20. They are usually 40 plus, 40 centimeter per second. So usually the velocity is higher, the L wave. So L wave 2 is in between your A and E and A, tengah-tengah tu. So dia have E kan, so tengah tu ada satu wave bump dekat sana. So that is your one of the sign of diastolic dysfunction. Okay. The rest of two susah nak measure. I also don't measure all these things because all these things are time consuming. You need times for you to calculate. It's not automatically calculated from the machine. So it's not easy to do all these things. If you are in doubt, then you do this. That's why it's important to capture, but you know measure is okay. You capture, then you can retrospectively measure later. So the paling senang adalah nowadays you can capture the view, you can do the strain later. So as long as you capture the view, then if kamu tak tahu bila kamu akan guna, mana tahu dia nak buat tadi, so bolehlah guna LA strain tu. They can measure the LA strain. All these are for study purpose previously, but nowadays they try to put in the guideline. Tapi LA strain is not widely available in most of the hospitals unless you buy the machine or buy the software, and then and you need to consistently do it. Then only you capture the best strain. Okay, same thing for your GLS. Okay, if you don't do it regularly, you won't get the results. And then each vendor have different measurements. Okay, tapi yang baru punya Philips dah include everything. Old Philips, the first version, Epic 7C kan, you only have they only use one border only, one marker only. Okay, GE use 3 kan, GE terus capture everything. Philips use only one. That's why when you do, if you do study later on, because when you want to publish, the people will ask you what method you use, because it's different when you want to publish. People will question you your machine that you use, because they want comparison is different. Okay, so it's important to capture the view. You can use it later on post processing later. Okay, macam most of my patient previously, I just capture only the view. So when you have the software, you just need to put in, and then the software will help you to analyze. Okay, this GLS is important if you have chemo patient, chemotherapy patient. Okay, so because your EF won't reduce so fast during your chemo time. So the first thing to reduce is the GLS. Okay, the first LV dysfunction that's going to start is your GLS. So if you look at chemo patient, when they started chemo, especially those that are on chemo drug yang macam anthracycline based, apa tu, trastuzumab for prostate breast cancer. So all these are drugs that can cause cardiotoxicity. So the chemo can cause the GLS to reduce first before the EF drop. Okay, so that's why if you sini tak ada oncology kan, siapa yang work dekat IKN tu, these are the way to monitor the patient with on chemotherapy drugs, because to measure the GLS for oncology patient that are on chemotherapies or checkpoint inhibitor punya chemotherapies, so they need to use the same machine, same operator each time when you do the echo monitoring. So their monitoring is very frequent, 3 months, 6 months, so it's very frequent. So can you cope with all this? Susah kan? So that's why it's always different operator. That's why the suggestion will be capture the view, use the same software, easier. Then you won't get different result. Because when you want to report the change in the GLS, it's going to change the decision for the oncologist, because they're going to change the regime or reduce the dose of chemotherapy, because it's going to affect the patient. So until now, overseas will start to use this, but Malaysia belum lagi. Okay, so we don't have cardio-oncology in Malaysia. So it's not easy because sonographer need to be the same person who do, and same machine and same patient each time that you want to monitor, because you are the one that know which view